Dr. Boockvar, we're going to try and go live now.
Okay, good.
And then we'll just test things. So this is a slightly different... Just bear with us a moment, sorry. Typing in Lenox Hill as a tag. And, are we live? Oh, great. So, have we got... Okay, so we've got one person on there. Let me just share this.
You're streaming your screen.
Yeah, you're streaming your screen.
Yep, I know. Okay. So, Dr. Boockvar.
Good morning.
Thanks so much for joining us. I think we've had a couple of technical problems and we are just expecting to bring our viewers over to this new channel that we've just made and a new stream. So we'll take it a bit slowly to begin with, but you're a very, very busy man, so I would try not to keep you for too long.
Well, thank you for having me, and good morning to everyone. Good afternoon, I guess, to you.
Absolutely. So it's 3 p.m. in London. 10 a.m. in New York. How's the weather over there?
It's pretty London-like, actually. Dark. a little dark and rainy, but it's okay. We hope we haven't had snow yet, so we want to remember what snow looks like, hopefully soon.
I know. We'd love some snow too. Absolutely. Well, I don't know. Something to take our minds off everything that's going on, right?
Right.
So, Dr. Boockvar, other than spending some time with Brain Book viewers today and speaking to myself, what have you been up to this morning?
Well, actually, today is my lab day. On Wednesdays, I go out to the laboratory. So I spent the morning in our tumor board. So we actually are part of a very large health system called Northwell Health. Our medical school is part of a 24-hospital juggernaut called Northwell. Lenox Hill Hospital is one of those hospitals. So on Wednesdays, I actually take a breather from my clinical practice, and I spend some time at tumor board at an outside hospital called North Shore University Hospital. So I did that this morning. I teach the residents from 7 to 7:30, do tumor board from 7:30 to 8:30, and then we start lab meetings from 9 to 11, except today because I'm doing this talk. We stopped abruptly about 9:45.
So sorry.
It's okay.
So, how many residents have you got there?
So we have 2 residents per year at the Zucker School of Medicine at Hofstra Northwell, which is the first new allopathic medical school, MD medical school in New York State in 40 years. And so we started this residency program about 7 years ago. It was an old DO program, an old osteopathic medicine program that got converted to an MD program. So we're really proud of our residents. Our last resident, David Bonda, just recently won the prestigious NREF award. We've had a resident win an NRSA award, which is a big National Institutes of Health research award. Both of them did work at one of our laboratories, which is Cold Spring Harbor Laboratory, home of 3 Nobel laureates. So we're really excited about this new residency program, and it gives us a lot of flexibility. They come over to us at Lenox Hill Hospital as a 6th year, I think the same year you are, and spend 6 months at a time learning complex skull base, cranial and endoscopic neurosurgery, as well as cerebral bypass with David Langer, cerebral revascularization, stroke, and of course spine.
Lovely. And do you have any comprehensive or hybrid kind of training there?
We do. In fact, we, like everyone else, endovascular neurosurgery is now a hybrid specialty, or I should say it's 90% endovascular and 10% open vascular. What's great about having a complex cerebrovascular surgeon like David Langer as a partner, he's one of the rare individuals that really has mastered open vascular neurosurgery, bypass neurosurgery. And so unless you get exposure to that kind of high-end vascular training, unfortunately, that's a dying field. And so we're seeing less and less well-trained residents come out trained in vascular neurosurgery. So we're spending a lot of time with our residents on that.
Fantastic, because I don't know how much you know about endovascular training in the United Kingdom. It's a little bit different. I don't want to tread on any toes or be too political, but within neurosurgical open training, at the moment there isn't really a role for learning endovascular techniques. And I was speaking to Professor Pascal Jabbour previously, and we had a bit of a talk at the European Association of Neurosurgeons, and he truly believes that you have to be comprehensive for your patients so you can offer them all kinds of treatment modalities. And I think a lot of us as trainees are itching to be able to learn those techniques and really try to apply ourselves in the vascular field.
Well, I think you're absolutely right. Yeah. And I have that same approach when I treat skull base tumors. Unless I'm facile in open skull base, in endoscopic skull base, minimally invasive skull base, you don't, and radiosurgery for that matter. Absolutely. You have to be multidisciplinary in your approach, or you're going to have bias, right? If you can only do an aneurysm open, you're only going to offer your patient open vascular surgery, which is not necessarily the best technique. So there's no doubt in the United States, at least, we're looking to be hybrid in a lot of fields.
Absolutely. Bit of a personal question from me. Well, a question I would like to ask you. Every trainee, every consultant or attending that you meet has their favorite neurosurgical operation. For me, it's the MVD. What's yours?
Actually, the supraciliary, supraorbital approach to an olfactory groove meningioma. I believe that is just a really slick, minimally invasive, maximally effective approach for a meningioma that's less than 3.5 centimeters in width. You can get from bilateral optic nerve approach. It's just, every time I do it, I think this is just a terrific operation.
Lovely. So we have quite a few questions that came in from Twitter, Instagram, YouTube, all sorts of places. Lots of people very excited. Yeah. I think a lot of people want to ask questions about Lenox Hill at the Netflix show. You've probably been asked 1,000,001 questions about this. But I think one of the main ones was, how has your life changed since the start of the show, both personally and professionally?
Well, look, I think anytime you have the visibility of a 9-episode Netflix series, particularly when there's so much attention on healthcare workers, my life has changed. I'm recognized a little bit more in public. I have an identical twin brother. He's recognized a little bit more in public, and that's all fun. But you remember, at the end of the day, we still go to the operating room. We're still operating. We're in the cockpit of the airplane that we fly every day, which are surgical ORs. And we go home. I go home to my wife and 4 children and puppy, and that doesn't change. And so, yes, it's nice to have the exposure. What I think is really terrific are opportunities like this, right? So what we've been doing, particularly now in the face of the pandemic, where telehealth, telemedicine, Zoom, in social media platforms, I get to meet you and I get to meet your audience, which I probably would not have done pre-Netflix, right? So to me, that is one of the most absolutely beneficial things that's happened to me, is the depth and breadth of the people, the emails, the DMs, the video chats that I've got to speak to people has been truly inspiring. From doctors to nurses to patients to politicians, organizations have just reached out expressing their love, their compassion. and how they were touched by the show. To me, that's an indelible mark of what we've gone through.
Fantastic. But with that attention can come negative attention as well. Have you had many experiences of negative attention, and how have you dealt with them?
You know, I was braced for negative attention, right? And Dr. Langer, who's my partner and also on the show Lenox Hill, we sat down and prepared ourselves for negativity, for haters, if you will, or for angry patients or colleagues or competitors or other health systems, or you name it.
Yeah.
And I can tell you that, and maybe it's just the way the show was filmed and how we were portrayed and how they closed the arc on our stories. We weren't out there as, you know, I didn't get paid a cent. I still don't get paid a cent. I haven't earned a cent from any promotion of the show after the release. Everything has been free. So we have been so pleasantly surprised by the lack of negativity surrounding the show. I can tell you I've had, and I want to just knock on wood here, we've had no negative publicity. You know, we were very nervous that somebody would find that we left a handrail down on a patient's stretcher and we'd be reported to the state, or, you know, my mask wasn't perfectly tied on episode 3, scene 5, and would we get reported? But you know what? The producers, which is Ulari Films, Adi and Ruthie, were just so wonderful, beautiful. Safety first for the patients, and privacy first. And we stood by that, and thankfully there hasn't been negativity.
Fantastic. That's good to hear. So, is it hard to manage being a neurosurgeon and a vice chair for the department? What are the main challenges that you face on a day-to-day basis, other than obviously being extraordinarily busy all the time?
You got to be efficient. Efficiency is king. And if you're not efficient, whether it's your vice chair or you're an assistant professor or you're a resident like yourself, I have 4 children, a new dog, a wife of 21 years, and I am constantly juggling. I always say it's like juggling tennis balls. You know, I have 4 little tennis balls to juggle. I got a puppy and a wife, and I'm vice chair. And it's just a question of being highly efficient and making sure that you just from a very young age, your age and even in medical school, really developing the habits to prioritize, systemically reach for your goals, make sure you're doing deliberate practice so your skill set gets more and more expert as your problems become more and more challenging. You want to be a quick surgeon without being hasty. You don't want to dilly-dally. I always tell my residents, learn, I don't know if you play sports, you probably play football, American soccer, but I'm an American soccer player. And I always say, move without the ball to my residents, right? It's not just about doing surgery and holding the scalpel. It's about being efficient, helping your patient get the paperwork done to get into the operating room, helping the nurse push the patient, going to get the patient from MRI scan. Move without the ball is a key to success in sports, and it's a key to multitasking.
Fantastic. Move without the ball. We'll take that back to the team. Stop moving. Do you have any kind of practical suggestions for time organisation for residents who will be coming up to the ends of their resident careers? We have something called a senior registrar role here, which I guess is the equivalent of the chief resident year, where you're probably in the hospital all the time, looking after a lot of patients, being a kind of deputy attending to all the attendings, possibly. I don't know really how to explain it other than that, but it's like your chief resident role. And I think there's a lot of expectation in that year. There's the trying to prove yourself as a very senior resident, as a junior attending, a new attending, trying to provide moral and pastoral support for the junior residents coming through, trying to be the best surgeon you can be. What do you think that the chief residents or senior registrars can bring to the table, and how can they really show their best?
Well, look, remember, your number one job is to learn how to operate. You'll never get an opportunity. There's a great book by Erickson, and we presented at one of our neurosurgical meetings a couple of years ago on the science of peak performance. You have to become a peak performer. How do you become a peak performer in surgery? Practice, deliberate practice, under the tutelage of a mentor that's going to give you feedback. When you're a chief resident or a registrar, you're in that moment where you have to make use of those, whatever, 10,000 hours where you're going to get that feedback about your surgical technique, because next year you're under the lights by yourself, and the headline on the operating room table is going to be your last name. And so your job is to do every case. We've had chief residents come through at every place I've been to, whether it was Penn or Cornell or Northwell now, who said, well, I don't want to do that case. It's a small case. Every case is a big case when you're alone as an attending. And your job is to get through the hump of every surgery. So every surgery has a hump, and you have to get over that hump. And there are times in that surgery when you think you're not going to be able to get over that hump, and you always do. But it's because of deliberate practice that you develop the muscle memory to get over that hump. So as a registrar, practice, 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 and teach your junior residents, practice, practice, practice. You're the mentor to the junior resident, and your attending is the mentor to you. And that's how it works. You got to learn, you got to practice, and you got to get that feedback.
Right. And that's become exceptionally difficult in the past few months. And there have been a lot of training opportunities lost, obviously. We've got fewer patients coming through the doors. The ones that do are obviously very sick. How have residents on your side of the pond found training opportunities, and are they facing the same kinds of difficulties that we are?
Yes, of course. But, we're back in full business now. In fact, at Lenox Hill Neurosurgery, we're about 10% over volume than we were pre-COVID. Now, some of that has been the serendipity of the Netflix show and whatnot.
Sure.
But look, you'll make it up. And if you can't make up the 6 months of operative experience that you've lost, I just offered you an opportunity to come to New York and do a 6-month fellowship with us. You got to get that mentorship. You got to find a mentor, and you got to get that operative exposure. There's a lot of value in just watching surgery being done by an expert. But
Absolutely.
Slowly, that mentor has to allow you to do a little bit more and a little bit more and a little bit more. One thing we do, which I think is terrific, is we take a graduate. I don't know if you know, Randy D'Amico is one of our new young partners. He just graduated from Columbia. He joined us as what we call the super fellow. We made him a junior attending where he can get some autonomous exposure, but he would operate every Tuesday and Wednesday with myself and David Langer. So we slowly took him out of his residency, put him in this junior attending super fellowship position, and we just really mentored the crap out of him. We fine-tuned his surgical skills. Now he's completely independent as our junior faculty. We're doing that with another graduate. So we feel that's the way you learn neurosurgery. Just because you get a certificate that you finished your residency doesn't mean you know how to operate.
True.
The first 5 years of your training, of your faculty position, are going to be extremely important. And you better have good partnership and good mentorship even when you're done with your residence.
That's a very, very good point. So it's try to find a unit that you like and where you get on with your colleagues and where you'll be mentored even as a junior attending or consultant. Absolutely makes sense. From the Netflix show, you seem to have a very happy, motivated, strong team ethic. What are the kinds of things that you do every day at Lenox Hill to keep your team motivated, keep them happy, keep the morale high?
It's an excellent question, and one we've been asked by organizations in neurosurgery, organizations at the highest level in the United States. And ultimately, look, we're all motivated by money, unfortunately, right? And so there are two things. One is we took away financial incentive. We're not incentivized to eat what we kill. We're incentivized to succeed as a unit. So I don't have to clip aneurysms to make money. I can give them to David Langer. I don't have to do complex spinal fusions. I can give them to Mitch Levine or Griffin Baum or junior spine guys. And they don't have to do endoscopic skull base surgery. So we are programmatically incentivized to develop the unit of Lenox Hill Neurosurgery as a group, not as an individual. And in the United States, at least, and I'm not sure what it's like in the UK, that fee for service model is what's killing American healthcare. First of all, it's leading to burnout, and it's leading to this disjunctive attitude in medical schools across the country. We got rid of that. That's the first thing. And then it really comes down to culture. Who and why are we part of the Lenox Hill Neurosurgery? We are drawn to this culture of collegiality, commitment, compassion, and caring. And you know it when you see it, when you're around like-minded people. We were blessed that Lenox Hill Hospital had never had an organized department of neurosurgery. There were private practitioners there. But when David Langer came over and ultimately recruited me and then everyone else, we had no baggage. We decided that here we had a nice hospital on Park Avenue associated with a new medical school, and we had basically carte blanche to really bring in the right people. And it has been just exceptional because obviously we're doing more neurosurgery now than most hospitals in Manhattan, including the big Ivy League institutions. And we love it. We're having fun. We're doing great work and we have great outcomes. And that's the most important thing.
And we can tell. Everybody's got FOMO. Everybody wants to be there with you. Right. So something that we do on BrainBook a lot is get patients to share their experiences, let themselves be filmed. We have a YouTube channel that's got procedures and cases, and we try to narrate things in a jargon-free manner. I mean, in the few years that we've been doing BrainBook as a project, we've only had one patient say no to being filmed and having their case put on YouTube. But having a few subscribers on YouTube is very different to the broadcast on Netflix. Did you find it difficult to persuade patients to put up their personal details and be filmed, and what kind of barriers did you have to that?
Well, it's a very good question, and I get asked that question a lot. And like you have just told me, 9 out of 10 patients say yes. And a lot of patients, when they were asked, and I asked them the same way you probably asked, I said, look, we're in the middle of being filmed for a documentary. The purpose is to tell stories of the human experience, both as a patient and a provider. There's no cost or fee associated with it. Your safety and privacy are utmost concern to us, and in no way impacts my medical decision-making, my approach. And I'm comfortable enough that the camera behind me is just a fly on the wall. And uniformly, most people said, this is such an important part of my life, and if I can have a meaningful impact on sharing my story with the next patient and the next family and the next provider, 9 out of 10 patients, like you said yes. They couldn't wait to share their story. And I am so honestly emotional when I think about how courageous these families were. And I don't know if you remember one story from the Netflix show of a gentleman who died subsequently of a glioblastoma. His daughter was getting married 4 months after one of my surgeries, and he wanted to go to hospice, and obviously we kept him alive because they all wanted him around for the wedding. And this is the most emotional of human experiences. And I got emails after the show released how grateful and thankful they are that they chronicled and documented these experiences for their own families. So we're just awed with the courage that they had as patients, and I think it's done a lot of good. I really do. I think it's one of the most unique medical shows that's ever been released.
I think there's something certainly very special to having a journey documented like that, and especially so professionally and such a high quality output as well. I think if I were, touch wood, I'm not, but if I was a patient, I think that's one of the primary reasons why I would want it. I'd want my daughters to see me later down the line, you know, as I was, and the journey that I was going through, and have it really nicely documented like that. So yeah.
There's one example exactly like that of a patient who subsequently passed, and in the Netflix show, he makes a joke when he was well and lively, and all of the medical students started laughing, and it's such an uplifting scene to have the family remember this patient in such a beautiful way. Is just terrific.
How long does it take you to get used to the cameras?
It took us pretty quick. You know, obviously what we do as neurosurgeons is a little bit different than even OB/GYN or the emergency room. We have a little bit more stress when the camera is with us. So one of the best things about how it ended up is David Langer and I are obviously very close, personally and professionally.
Yeah.
We were able to, and our offices are right next to each other. So just being able to go through it with a co-pilot like Dr. Langer, you know, even in the beginning was very useful. But again, kudos to the cameraman, Adi Barash. He just was so just smooth and understanding, and just made us feel very, very comfortable very quickly.
Yeah, you were saying that you had you've got a good relationship with Dr. Langer. I put a tweet yesterday saying, you know, Dr. Boockvar's joining us tomorrow, you know, make sure you get in your questions. And he tweeted saying, I've got so many questions. And I said, why don't you join us? And I was secretly thinking that he was going to join us, but he's not here. Does it worry you?
He may show up.
What's he planning?
Kind of guy. Yeah.
Okay. Some of the questions people were asking were about clinical research, and your department's known for research as well. You're very well known for research, and I've definitely seen the cure glioblastoma on Instagram. So, can you tell us a bit more about your glioblastoma research?
Sure. So I started my glioblastoma research when I was a resident like you. I trained in Philadelphia at the University of Pennsylvania. In the late 90s, when all of the embryonic stem cell research started basically out of University of Wisconsin in Madison at first, and I started looking at stem cell biology in glioblastoma. That's how my first passion in glioblastoma started. And then I began to be frustrated with the impermeability of the blood-brain barrier as it related to glioblastoma. And one thing led to another, and I looked at blood-brain barrier disruption, started looking at some of these large monoclonal antibodies like bevacizumab and cetuximab, and looked at ways to overcome the blood-brain barrier. And I'm still obsessed with overcoming the blood-brain barrier. So my clinical research has focused on overcoming the blood-brain barrier. And every year I'm writing a new trial. For example, I recently wrote a trial where we're harvesting laparoscopically omentum, much like you would do a synangiomatosis case with omentum, like an omental cranial transposition. In the omentum is something called milky spots. Milky spots have a lot of inflammatory cells, and actually you can actually bypass the blood-brain barrier by just putting fat on the human brain. And so we wrote a trial, we got it approved by the FDA for 10 patients, and that's going to be our 2021 new
Fantastic.
clinical trial. So, you know, it's fun to come up with new ideas. Obviously, they have to be safe, they have to be scientifically proven. But I challenge my nurse practitioners, my residents, my whole brain tumor center. We want to be the part of the big consortia trials, but you know what? That's not where the energy is. You know, it's like being in your own innovative think tank when you can come up with a new product, a new design, a new delivery, or a new technology. That to me is what clinical research is all about.
Fantastic. Can't wait to see the results, although it's probably going to be quite a while until we see any data, obviously.
We should have plenty of patients lined up, but again, we don't rush these things. Clinical research takes a long time. In fact, my intra-arterial drug delivery trial, which I started in 2009, just finished this year. So we're actually at 1 o'clock today. I have a meeting with a statistician. So that's a decade for one
Wow.
trial. So this stuff takes a long time. You have to persevere and just keep going.
It must feel good, though.
Oh, it feels great.
Probably not to be that statistician, though.
They love, listen, good statistics are the key, right? So you're seeing it in your Oxford COVID trial with AstraZeneca. Statistics is everything. Even in the AstraZeneca Oxford COVID vaccine trial, there were some problems with some patients didn't get the correct dose. They got half the dose of the COVID vaccine. That is absolutely catastrophic for a company like AstraZeneca. And in the UK, the Oxford vaccine was the leading candidate for many, many months. So to make sure you have a statistician, to make sure you have the right people in your clinical research arm is just of utmost importance.
Hear, hear. Statisticians are like gold dust here.
Yeah.
You just can't find them. So, in the show, there's a couple of awake surgeries, which seem to be very rewarding. You seem to take a lot of joy from them and satisfaction. How do you think awake surgeries can benefit patients? And what are your views on awake surgery as a whole?
So look, I love awake surgery and I hate awake surgery. You really have to be good at picking the correct patient. There's no worse feeling than, and some of this was documented in the show, David and I were operating on a young girl who was in extreme pain during the operation when she was awake. And that means we didn't anesthetize the pin sites as much as we should. And, sometimes you can't predict how the brain is going to, swell up at you. Remember, by intubation, you're hyperventilating a patient. So intubation is one of the things we take for granted. When a patient's awake and retaining carbon dioxide, that brain is going to be awfully full. And God forbid they have a seizure or they're complaining of pain or they have speech arrest. It could be one of the most miserable cases you do, depending. Or it could be just a lovely experience where the brain is relaxed and the patient's cooperating and comfortable. So we just have a terrific team for awake brain surgery. We have an unbelievable neuropsychology staff that talks to the patients during surgery. They've met with the patient before surgery. We have an incredibly group of epileptologists and neurologists, neuroanesthesiologists. It really takes a team effort who are very comfortable. Don't just do an awake surgery because you think it's cool or because you think you're supposed to. It's not going to end well, and it's not going to end well for the patient. You really have to have a team that's experienced in doing this, and you have to choose the right patient. If you get a patient who, let's say, has some speech issues now, or perhaps speaks a language that you're not familiar with, or has a tumor, has a full brain on MRI because of a large tumor, that's a patient that you could run into trouble with.
Absolutely. And, we talk about a multidisciplinary team in awake surgery, and you only truly realize how many people there are there when you turn around and look around and think, oh, wow, the whole neurophysiology team's here. We've got speech and language physiotherapy, medical students that used to come because they've heard there's an awake surgery happening, and oh my God, that's incredible. And before you know it, you're having to send people out. Well, not me, my boss, but, whenever I've been a resident doing awake surgery with my bosses. But honestly, the theatre, it feels like theatre in the most genuine sense of
and don't get swept away by that. Your job is, once those blue drapes go on, you're in muscle memory mode, and
focus.
You're again at peak performance, and everything else is, yeah, nothing else really matters. Your job is to fly that airplane.
That brings me on to flow and grit flow, as
Yeah.
you've coined. I gave a talk on something called ikigai a long time ago, which is a Japanese word for seeking purpose in life and finding your purpose in life. And one of the main components of that is being able to achieve a flow state. And as a surgeon, as a resident, attendings will always tell you that once you're in that flow state, that you don't want it to be interrupted. It's almost a state of Zen, right? Can you tell us a bit about grit flow and how you apply it in your day-to-day? And we've seen some examples of how you try and achieve this in Lenox Hill, but can you just talk us through it?
Sure. So I like you, I've always grappled with how do you put it all together? So a couple of years ago, I read a book called Full Catastrophe Living, and I just want to, I think this is a very, very powerful book. Full Catastrophe Living is by John Kabat-Zinn, and he is essentially at least the American grandfather of mindfulness. And that's a very powerful book that I think anybody and everyone should read. There are three main concepts that I think are very good for stress reduction. One is grit. How do you utilize grit to achieve peak performance? We talked about this earlier. And again, Grit, which is itself a book by Angela Duckworth, is worth reading. You mentioned Flow, which is also another important book that was written in 1990, which talks about that state of really just walking along a path above the path, where everything is just seamless and you have reached this really purposeful moment. And we as surgeons yearn for this during surgery, where you don't even realize the moves you're making because the muscle memory has taken over and you're just in this perfect, as you say, Zen state where your mind is not wandering. You're not in what we call default mode thinking, which is basically this wandering mode. And I put together these three terms, grit, flow, and mindfulness, to help me. I didn't really care about anybody else. I wanted something that I can utilize to make myself a better surgeon. Grit allows me to achieve the flow state. We talk about deliberate practice, being able to have the mentorship and the feedback to develop the muscle memory so that you can achieve flow. You'll never get into a flow state unless you practice, whether you're a soccer player. Michael Jordan for the Chicago Bulls used to talk about the flow state, whether you're a concert pianist or violinist, or whether, of course, you're a surgeon. You must yearn to be in that flow state. And there's something called the flow channel, which is the higher your skill set, the more likely you are to overcome bigger problems. If you're a surgeon and you have a low skill set and a big problem, you're not going to do well when that aneurysm ruptures. If you're a surgeon with a lot of skill and you're only dealing with small problems, guess what? You're going to have burnout because you're not going to be using the skills that you've trained for. So we want you in that flow channel. We want you where your skill set matches the problems and you get into flow. One of the utilizations of mindfulness is how do you handle trouble when flow gets disrupted, when the aneurysm ruptures, when the patient's brain starts herniating in awake surgery. That's when you have to understand that you have mechanisms we talk about with mindfulness training that can help you calm yourself down, help you stop catastrophizing, and use muscle memory to fix your problem.
And I mean, that's the epitome of what we aim for as surgeons. And you're right, especially in things like trauma, and at the Royal London we're a major trauma centre, and as junior residents we cut our teeth on trauma, and it is hard and fast and the learning curve is steep and we've got good mentorship. But you can definitely tell the difference, even within a couple of months of doing trauma surgery as a neurosurgeon, where your mind is everywhere. How do I stop that bleeding? How am I going to do this? What do I do with that? Oh, that contusion's just started bleeding. What do I do? To when you're a little bit more senior, and it's just everything just happens and happens and happens. And the only time you call your boss.
Why do you think that is? Because you've developed muscle memory. You've also developed a skill set that you're entering that flow channel. Your skill set is meeting the problem, and you're able to handle that. It only comes with practice. There's no other way to do it. But what I want you to do, which is what I did, is when I went home, I had in my old Sony Clie, which was this huge cell phone that was one of the early cell phones. I would write tons of notes, little things.
Okay.
I would take away tidbits and I'd study them, and I'd remember them until they were, I just kept studying little tidbits of each case after I did them. And the key also is anatomy. I don't know if you know who Yogi Berra was, but New York Yankee. And he used to have yogi. He used to have yogiisms. One of the things I like to say is surgery is 90% anatomy, 9% skill, and 1% luck. And your anatomy is so important for your success as a surgeon, as a brain surgeon in particular. So I have studied the Roten textbook for anatomy and surgical approaches. We go through it every Wednesday with my residents. I know anatomy of the human brain inside and out. And that helps me in neuroradiology, it helps me in surgery, it helps me in physiology, it helps me in research. You must know anatomy. I need you to know what the indusium griseum is. I need you to know where the tapetum is. I need you to know what vessel the medial posterior choroidal artery anastomose is to. These are important little things that make you a better surgeon. So study anatomy, do the cases, and you'll see that you're going to be in the flow state sooner than you thought.
Can't wait. Yes, sir. I'll get out the anatomy books. Right. So, neurosurgery. I'm going to get a little bit, not darker, but our profession is very, very well known for being bleak. Poor outcomes sometimes, maybe a lot of the time. A lot of medical professionals view us as, the doctor deaths of the profession, never have any good news, that kind of thing. We know that that's not the case, but a lot of the times it can feel like that. And I think that as even residents, as attendings, we deal with probably quite a lot of it, more than is comfortable. Over your career, first of all, how have you managed to deal with a lot of the death and the grief and the really, really difficult cases?
It's an incredibly good question. And the way I first want to tell you is if you don't feel grief and you don't feel emotion, there's something wrong with you as a neurosurgeon.
Yeah.
And what we don't do well at telling residents and training is that it's okay to have these emotions. And it's okay to cry in the stairwell. And it's okay to let your guard down and show emotion, because we're seeing absolute devastation at times. Whether it's I saw a 19-year-old hit in the head by a subway train. We've seen the most tragic of tragic things. And you have to develop this coping strategies like you develop muscle memory, and recognize it's okay to have these emotions and to share those emotions. We're not good sharers in neurosurgery. I tell you, David Langer and I are not afraid. In fact, when we have a complication, he's the first guy I go to and say, David, I've had this complication. It's just, and he talks me off the ledge, and he'll say, look, there's nothing you could have done. In fact, you did a great job, subsequent to the complication. And again, having that mentorship and having a colleague in the department who you can share ideas with. Of course, I'm blessed with a loving wife who has been with me through my residency, so she understands a little bit of, and I bring it home. Some people say I don't bring my work home. Of course I bring my work home. And my wife hears me on the phone. I had to give a very, very difficult conversation to a wife of a glioblastoma patient last night from my kitchen. And so my kids hear it, my wife hears it, and I think it's very important to share. You start bottling this stuff up, forget about it. You're gonna hurt
Yeah,
emotionally.
I agree. I think the first year and a half where we started doing more neurotrauma emergency operating, there is certainly a feeling that you need to be, bullheaded, strong-headed, very focused, and just have an almost macho attitude towards it. And you see, like you said, you see horrendous things that you don't process properly, and you take it home with you, and you don't really talk to people about it. You don't know whether people understand it. And I realised that personally I had been bottling things up for a year and a half. And as you get more tired with the calls and residency gets more difficult, the emotions start bubbling out a bit more. And until I started talking to my wife about it, I didn't realise just how much these things had affected me and how much I had bottled up inside. So,
Well,
it's
I
nice
think
to
one of
hear.
the things the Netflix show does show, and even my wife said it, but I had people from all over the world reach out and said, "My gosh, I didn't realize what you guys really take home every single day." And for example, in the COVID episode where you see Mirtha Macri, our emergency room doctor, crying in the car on her way home that night, it's just devastating. And
Yeah,
you got to be. It's okay. You can be a great doctor who's empathetic and compassionate and emotional and a great surgeon at the same time. There are ways
yeah,
to be both. You don't have to be an asshole to be a great surgeon.
it's true.
Okay? That's true.
It's true. And that's what it feels like that's what we're raised on.
Right.
The John Waynes of surgery, the heroes and the role models were all like that, and you feel like you have to be like that. But yeah, you're absolutely right. There's no need.
You don't.
Right. That's probably quite heavy. We'll move away from that for a moment. How do you do it all? That's from Momo Rizza on Instagram. How do you do it all?
Well, I do a lot of moving without the ball, and I run to open space, and I create, right? And those sounds like sports terms, but it takes a lot of juggling. I surround myself with like-minded individuals. I married a efficient, effective woman, and I'm quick. I multitask. I know some people call it the wrath of John, in that I'm very, very regimented. Like David
Okay.
Langer would say, "John, come out for a drink," and I say, "Nope. You know what? My daughter's got a flute concert at 8 o'clock. I got to be home at 6:45. I got the. It's it takes saying no to people. You can spend 24/7 in the hospital every single day, 365 days a year for years. There's enough work to be done.
Yeah.
But unless you say, no, I need to leave, I have other priorities, or I have to work on, it's not easy for people to let me do lab work on a Wednesday. I could be doing 3 more cases today, right? But I said, no, I'm doing clinical research. I'm running a laboratory. I'm studying anatomy, and I'm spending time by myself or for myself.
Yeah.
And that's important because burnout is the worst case scenario, right? And heck, if I go play 9 holes of golf this afternoon, which I'm not doing because it's 30 degrees, even better. So you got to put some time in for everybody in your life. You got to make time for yourself, and pay attention, be efficient.
Look after yourself, because no one else can look after you the way you do.
Correct.
Right. We have a lot of undergraduates asking about whether you were a good undergraduate and whether you were like a straight A student or whether you were a bit of a dosser like I was, or so tell us, were you a straight A student?
So the answer was, I wasn't a straight A student, but I had really good work ethic, meaning that I went to an Ivy League institution, and there were a lot of people who maybe had a higher IQ than me. And so I did reasonably well at Penn, enough to get into medical school, where I really worked hard. And that's really where I excelled. I really felt like I needed to, in order to get into a neurosurgery residency program, I needed to, and I graduated first in my class out of medical school. But it's not because I was smarter than everyone. I just worked harder. I really did. Work ethic is going to be important for the undergraduates who want to go into medicine, especially, there's something called the Fauci effect already. I don't know if you've heard of the Fauci effect. The Fauci effect has increased medical school applications by a significant percent already. So you have to work hard. And, I was social in college, but I also said, you know what, I have an identical twin brother, I told you. And he'd say, John, I'm going out to a pub, come with us to watch American football on a Sunday. I said, you know what, I have to study biochemistry. So those are times, again, where efficiency starts. You have to say no to people. You have to prioritize, especially if you're going into medicine. You got to put in the work.
Yeah, I completely agree. Work ethic. I was terrible at taking exams, terrible at science.
and it's not all IQ. No. And you've seen it. Some of the smartest people make the worst doctors.
Absolutely.
And so some of EQ as a physician is just as, if not more important than IQ. Your emotional quotient is just as important. So it's a balance. And what's painful for me, and I sit on a bunch of admissions committees, is when you see people with, not accepted into medical school who probably would be terrific physicians because maybe their board scores were just not at the cutoff. And you get these very smart, I don't know if I should say this, but at Penn, we fired 3 Yale medical school students in a row in neurosurgery.
Wow.
They were really smart, but they couldn't survive.
Yeah.
I mean, you would say Yale, it's a fantastic institution. One other story about that is I have a fellowship. We call it a pre-medical school fellowship for a year. And a couple of years ago, I had an opening. I have an opening every year. And I had a Cornell University graduate, college student. And all of a sudden, someone said, well, we have one other student from Florida State University, and which is not as reputable as an Ivy League institution. So I did a Skype call with him, and I flipped up the laptop, and here was this very energetic, terrific kid from Florida State University. And I basically closed the laptop. I said, bring that kid up to New York. We're going to hire him. And I bypassed the Ivy League. Within 6 months, we had offered him a full-time job. And 6 months later, he got into medical school because of his recommendations. So here we took the Florida State kid over the Ivy League girl, and he has blossomed into, he got a full ride for a PhD program. You said you may be interested in a PhD. He had a full scholarship for a PhD. So some of it is serendipity, some of it is EQ, and some of it is IQ.
So med students, undergraduates, work ethic, consistency, being keen, and turning up. You heard it here first. And it won't be the last time you hear it either.
And be nice. Be nice to everybody, because someone in your classroom or your teacher or your friend is going to help you down the road, whether it's a job opportunity or something. Just be nice. Don't be a jerk.
Yeah. Thank you. It's good to reiterate the point. It's not all about your grades. It's not all about the numbers. You need to be emotionally intelligent. It's really important. Right. Shani Jaggernorth. I never know how to say these social media names. What was the most complicated surgery you've ever done?
Oh gosh, that's a good question. I'm not going to even say the most complicated neurosurgery, because the first thing that just came to my mind was my very first operation as an attending. And I think it's worth sharing because ultimately, right, that's the first operation I did by myself. And to me, that will always be, even though it wasn't that complex when I look back on it, it was the first time. So my advice when I finished my residency that I was given was do really simple surgeries first. Maybe do lumbar discs or something simple, right? Well, I was covering an outside hospital, and a 55-year-old Ecuadorian man came in with acute obstructive hydrocephalus. And sitting in his basically where the cerebral aqueduct meets the fourth ventricle was a cystic lesion that was suspicious for cysticercosis. Now, you know that cysticercosis is rarely necessarily operable. You can treat it with anti-parasitic agent, but it was causing obstructive hydrocephalus. And so in a long discussion with the infectious disease people, instead of just shunting him or giving him anti-parasitics, they said, John, could you go in and take out the cyst? This is my very first case as a surgeon. So we were at a small hospital in Brooklyn that had no surgical navigation. And I turned the patient prone on a frame. And in Ecuador, a lot of Ecuadorian men have very small necks. They're stout. And so I didn't have a lot of room to do a posterior fossa craniectomy. And here I am, straight out of my training, no navigation. And as I do the craniotomy and I'm splitting the vermis and I'm in the white matter of the vermis, thinking that all is peachy. I have my ultrasound, but the machine is not working. The image is a little hazy. And I start worrying that I'm somewhere in the man's brainstem at this point.
Yeah.
Right? Because it's your first case. And this really goes back to everything we've talked about today. Was I in flow? Did I have the muscle memory? Was I using mindfulness to get myself out of catastrophizing or thinking the worst case scenario? And this is what happens as surgeons. I'm digging along and I'm thinking, oh, this is great. I'm in the vermis, or maybe I'm in this, superior cerebral peduncle maybe, and then all of a sudden you're like, wait, am I in the floor of the fourth ventricle? Am I at the top of the, you start worrying. And sure enough, as the beads of sweat are building on my brow, I see a brownish hue, and I take my tumor forceps and I reach in and I pull out this brownish, what looked like a dirty golf ball, and I wiggled it and I said, I can do this. Yeah. And I had I removed a cysticercosis cyst as my first case as an attending. So,
that's incredible.
I'll always remember that. It's not my most complex case. We've done incredibly bypasses and endoscopic cases, skull-based cases, you name it. But those cases are the most valuable because you get over the hump, you realize you've been trained for this. You're made to do this. You're training to do this. And make sure you always have somebody that you can call for in an emergency just to help you through the hump of a case. You should never be the only neurosurgeon in the building. That's rule number one, if there's anything complex going on. And if you're the only neurosurgeon in the building, make sure there's another vascular surgeon in the building. Somebody that, let's say you need help. You should never be the only surgeon in the building because you may need help. You may need someone to come in and just pat you on the back and say, you got this, I'm here for you to help.
Yeah, I think we've had, even as residents, sometimes it's really nice when we'd be finishing a 24-hour call and 8 o'clock is in sight, you're getting ready to do the handover, and then 7:30 bifrontal decompressive craniectomy, and you think, all right guys, you text on the WhatsApp group, I'm going to be out for a few hours. But then sometimes they'll do a quick handover and the day registrar will come down and give you a hand, help you out, help you close. And you know what? Those are the days that were really good. They're the ones that I found really satisfying. Operating with a friend. And I wouldn't say it was fun, but it was certainly not a really grim experience. It really elevates it. And yeah, it's just fun.
Listen,
and you know who I'm
now,
talking about.
yeah, and I love operating with David Langer. We have fun. We have a
Yeah.
complementary skill set. Our hands just work. First of all, we both trained at the same institution, so we're sort of fundamentally similar. But we just have a give and take. We know our strengths and weaknesses. You really are a much better surgeon knowing that there's two brains working to make these decisions. It's really, it can be a lot of fun, and I think it's actually better for patients.
Yeah. And whenever I've watched that, I think the only time I've watched two surgeons operate together like that were two general vascular surgeons, two consultants operating on a ruptured abdominal aneurysm together. I don't think I've ever witnessed anything like that again. I mean, they didn't speak to each other, they didn't look at each other, their hands were just working in tandem. It was incredible, absolutely incredible. And yeah, when you see that, it does make you a little bit jealous. You wish you had a kind of surgical partner that you could work with on cases. And so it's nice to see that you have that with Dr. Langer. And yeah, it'll be great one day to maybe come and watch you guys operate in person.
Please do. And anybody, just send me an email. We're always happy to. Post-COVID, we'll have more visitors, of course.
Perfect. Are you happy for us to put your email in the description?
Absolutely.
Fantastic.
No problem.
That's very kind. Do you have any messages for our audience which comprise patients, general public, healthcare professionals, medical students, anything that you want to tell our audience?
Well, I think, first of all, it's been a spectacular year for good and bad, right? COVID allowed us to reset our societies, right? We had a lockdown, we were sheltered in place, we were quarantined. We basically had to turn inward and see what was most valuable. I was spending more time with my children and my wife than ever before. And I think we've had just an incredible year with social unrest and social injustices here in the United States. We're never going to go back to 2019, which is a good thing. We've made changes in healthcare that should have been made pre-COVID years ago, whether it's just in sanitation, in telehealth, telemedicine, ways that you and I are communicating now. 2019 we're never going to be 2019 again. And so we have an opportunity now to take everything that was bad about 2020, whether it was social unrest, racial injustice, COVID, healthcare issues, political unrest, environmental catastrophe, you name it. And now with these modalities and the way we reset each of our clocks, I think we're going to be really better for it in 2021. So 2020 may go down as a year of complete unrest, but I think it's going to go down as a year that you're going to be able to notice in any documentary, any magazine, social media, anything that was pre-2020 is going to be very recognizable, hopefully. And anything post-2020 is going to be a whole new experience. So I think it's going to make us all better, stronger, better individuals, kinder, more compassionate, more just. And I look forward to it. I really do.
I certainly hope so. There's one final question which is on everybody's lips. Lenox Hill, Season 2, yay or nay? Put us out of our misery.
It's not a nay. That's all
I'm going to
I can
hopefully
say
have
right
lots
now.
of screaming fans now. That'll make one of our BrainBook team members, Inez Correa, she sent a load of questions as well. She's a super fan. She's one of the UK brain turns.
Oh, great.
So she found this really, really exciting as well.
Oh,
so that's a shout out to Inez. There you go. Dr. Boockvar.
Thank you, Inez, for being an ambassador.
There you go. Dr. Boockvar, it has been an hour. You are an extraordinarily busy man, and we don't want to keep you as much as I think our audience would love for me to keep you here for the rest of the afternoon or morning in your case. I wanted to say thank you on behalf of myself, the BrainBook audience, and whoever else is watching for your time. and for a brilliant insight into your hospital, the way you work as a neurosurgeon, and your thought processes in general. I had a great time interviewing you.
Well, thank you so much. Best of luck to you and to the entire audience. Thank you for having me. And if there's anything I can do for you personally or for anybody else, please don't hesitate. We make time for everybody.
It's very
Have a
kind of you.
happy, healthy holiday season, new year, and we look forward to seeing you all in person soon.
And you too. Great. Have a Merry Christmas.
You too. Thanks again.
Lovely.